All right, so we are recording. This is the beginning of Module 4, and we're racing toward the midpoint of the semester. Racing towards it. So let's go ahead and get cranking. Depressive disorders. Now we're finally getting into diagnostic criteria and assessment and treatment. Please be on the lookout. We're going to record and post into the files a supplemental PowerPoint or recorded lecture with more specifics about medications. We can't go into a lot of detail about lots and lots of medicines. We just want to introduce the 80% main important concepts, and then we'll hit more specific take-home points about medicines in another little recording. But let's go ahead and get started. What percentage, those of you who are seeing adults, what percentage would you say in an outpatient setting depression is either a primary diagnosis or a significant component to the patient's presentation? What would y'all say? Percentage that depression is an issue. 80, 50, lotsy, 90, 80, 90, 50, 70. So a good bit. That is exactly right. Depression is depressive disorders. Gerard's seeing 85-ish% right. Depressive disorders, whether it's primary or a secondary diagnosis, is one of the main reasons why people, adults, seek outpatient psychiatric care. It may be a reason, or complications from depression may be a reason people seek inpatient, but this is a huge segment of the population we care for. So how do you know if you're looking at a patient with major depressive disorder? Well, you need to know what are the symptoms, what are the diagnostic criteria. DSM-5 will tell you this. What we have here in the context of major depressive disorder are symptoms of a major depressive episode. And you must have the primary feature, and I encourage y'all to absolutely know what the primary features are. Depressed mood or loss of interest. So one of those two. You need to have one of those two for at least 2 weeks. Most of the day, every day, for 2 weeks. Not, oh, I had a good couple days where my energy was fine and I enjoyed stuff. Oh, but then it just came back. You're talking about feeling depressed or down most of the day, nearly every day, for 2 weeks or more. That's your primary feature of a major depressive episode. And if it lasts for more than 2 weeks, and there is clinically significant impairment associated with it and a significant change in functioning, then you've got yourself major depressive disorder. Additional features that you want to ask for are those listed here. This is straight from the DSM-5, which is quoted in SATIC. They have the little boxes. I think it's a different color, the diagnostic criteria boxes. That's DSM-5. And these are the things you're asking about and listening for when you're interviewing patients. Sleep is huge. The odds of someone meeting criteria for a major depressive disorder and not having some sleep disturbance is almost zero. You're going to have, and typically, difficulty sleeping, falling, staying, early morning awakening. So sleep, somebody says, oh, I'm just so depressed. The first thing I want to ask them about is, how's your sleep been? Because it's also a pretty benign topic. They're not having to talk about their feelings or anything, more stigma attached. There may be associated with that a loss of energy. They just feel tired a lot of the time. Disproportionately tired to the amount of activity that they're doing or the amount of sleep that they are or are not getting. Have y'all worked with folks who are quite depressed and you can just see it? They don't have to say anything or do anything. You can see it. Karen's saying yes. There's a deflated posture. There's this downcast gaze. There's minimal affect. They just look. It's normal human functioning just turned way down. Sleep, not happening. Appetite, not happening. Energy, not happening. thinking, decision making. Nope, not happening. So that's just the way that I kind of view a major depressive episode. It is on a spectrum of typical human behavior. It's there. It's just really turned down. You will hear it when people are talking, the guilt or worthlessness. People may describe themselves as a burden to family members or a drain or, sometimes I don't feel like a very good husband. I don't feel like a very good worker. There's just a very negative self-evaluation. And suicidal ideation. This is something that's a very important point, and we're going to talk about it a little bit more on the next slide. Most people who are depressed, who meet criteria for a major depressive episode, not I'm bummed out from some situational thing, but most folks who meet criteria for major depressive disorder think about suicide. Most people who are depressed think about suicide. That's why it's included in one of the 9 diagnostic criteria. It distinguishes a depressed person from a not depressed person, because most people who are not depressed don't think about suicide. So it's a really important question to ask people because it distinguishes the severity of the depressive episode. So very important to ask. When you read through Stahl, because Stahl is trying to match symptoms with structures so that we can match medicines to those to try to correct the malfunction of those structures. Something to think about when you're listening to people. Are they presenting primarily an increase in negative affect, which you see here? Are they sad, tearful episodes, kind of restless, edgy, trouble falling asleep, trouble staying asleep? Are they snappy and irritable? Are they having these guilty, negative, self-evaluative kinds of thoughts? Men in particular, and this goes for boys who are 6 and men who are 26, 36, 46. They may not endorse tearful episodes or what they would call sadness, but they will endorse, and other informants would say they're really irritable. They are easily frustrated, easily snappy, grumpy, grouchy, irritable. That's a more common presentation of depression in men. It's not to say that men don't feel sad and they won't have tearful episodes. Happens plenty. But just because someone doesn't say I'm sad, they say I'm really irritable, don't rule out depression, in particular with adult male patients whom you see. So those kinds of sad, irritable is more associated with serotonergic dysfunction than with dopaminergic dysfunction. When you think anxiety, you may also think norepinephrine malfunction, for lack of a better term, just because of its ability to regulate activation and to some extent drive, energy. Because sometimes people will feel like when they are restless, they'll feel like I just have this frustrated, I don't know where to put it, and I'm just, That is more of a serotonin, norepinephrine thing, as opposed to decreased positive affect. I don't enjoy anything. Nothing feels good. Nothing sounds good. I want to lay on the couch. It's hard for me to even get up and go to the kitchen and make a sandwich. Blah. Yuck. Nothing. That is decreased positive affect. So when you're listening to patients, try to filter through to the extent that you can. This person seems to be presenting with an increase in negative affect versus a decrease in positive affect. And that matters because you may be able to target those symptoms more precisely early on with different drugs. When y'all read about that install or listening to this, is that kind of ringing a bell? Are y'all thinking of patients you've seen that maybe fit one description more than the other? Tracy says, yep. So Tracy's all over this. All right, good. And it is helpful in that the more precisely you can target the symptoms, the more precisely you can pick a treatment. So a major depressive episode, which is what we just described, becomes major depressive disorder when it meets the remaining DSM criteria, which is going to include impairment in functioning and clinically significant distress, and it's not better accounted for by a substance issue, and it's not better accounted for by a medical condition, and it's not something other than this, which requires due diligence. Major depressive episodes may occur one time in a person's life, or they may, weeding out medical issues, which we'll talk about also in a little bit. Major depressive episodes may be recurrent, in which case you would diagnose major depressive disorder. You have to specify, is it single episode, meaning this is the only one they've ever had, or if they've had one before, it would be recurrent. And then you attach a specifier. So major depressive disorder technically is not an accurate, it's not a complete diagnostic label. It has to be major depressive disorder recurrent, moderate, or recurrent, severe, with psychotic features, recurrent, mild. So if you're getting feedback on your notes that you submit, that's because major depressive disorder is not a complete title. It requires a specifier to be more specific. So MDD, it's diagnosed twice as often in women. The mean age of onset is 40. What's the relevance of that? Not real important. The main thing you want to attend to is that the most common age of onset, typical age of onset, is going to be 20s to early 30s. Potentially after, could be after a particularly difficult, stressful time. You always ask about, did anything change kind of before you noticed this 2 months of significant such and such? Stress hormones create a unique environment in the body that will change it will change the presentation, the manifestation of genetic material. So don't underestimate the impact of psychosocial stressors. Men often have comorbid substance use disorders. Women often have comorbid anxiety disorders. So if you're working with somebody who meets criteria for MDD, you want to ask, maybe be a little more vigilant in your assessment of the most common comorbidities. SADC as well as the DSM-5 do a really good job with kind of epidemiological data. Do men get it more than women? What's the typical age of onset? Are there other typical factors preceding it? Typical comorbidities? All things you want to start filing away. I recommend making like a sheet of paper with MDD, sort of your demographic breakdown, age of onset, women have it more than men, really something that looks a good bit like this. Gender differences, maybe differences in presentation based on age. Neurotransmitter involved, classes of medicines that are helpful, just to help you really start filing this stuff away and packaging it in your brain. Fatigue, sleep disturbance, most common comorbidities. A majority will consider suicide or have passive suicidal ideation. Ideation, by the way, is a collective noun. It never has an S at the end of it. Suicidal ideation, which is thinking about it, very different from attempting or threatening. So, of course, you want to ask about intent, plan, means. And that will tell you, they're like, no, I just think about it sometimes. I just think about death, or just think about what it'd be like if I didn't wake up, or I wonder if it'd be better if I wasn't here. But I'd never do anything. I have XYZ protective factors preventing me from that. So suicidal ideation just requires further assessment. It is going to be present more often than not in someone who meets criteria for MDD. In adolescence, it tends to have a more, you would think, maybe more dopaminergic, a more anhedonic presentation. I don't want to do anything, don't want to see anybody, I'm going to stay home, I don't care, who cares about school. Substance use is a common coping mechanism. It's always available. In children, younger people, so I would say, 10 and 11 and younger, you may look more so for irritability than that anhedonic presentation. And you'd also want to ask family history. It is not typical for depression to present in someone younger than 20. Sure, it's possible, but statistically, it's more likely to present later. It is certainly capable of presenting in younger people, but just remember, that's kind of sort of a statistical abnormality. It makes you want to ask about situational, family, medical history, family psychiatric history, those kinds of things. Just some terms that I think actually one of your classmates had mentioned a couple of weeks ago in class, the difference between melancholic and atypical. That a melancholic, and these are really sort of more, I guess, older kind of terminology, someone that's a pretty typical depressed presentation, that the person loses appetite, has difficulty sleeping. Atypical would be people who tend to sleep more, and they sleep, 16, 18 hours a day. And that may eventually present as something entirely different than depression. So you may have folks with depression who sleep too much. It's just not the typical. You wouldn't rule out depression per se. You would just be maybe more vigilant down the road to maybe a development of a bipolar mood disorder. Maybe a little more of an impulsive substance use kind of presentation. Next semester, we're going to go more in depth about these symptom presentations for a variety of disorders for pediatric population, for geriatric population. Depression is not a typical sign of aging. So you want to be alert to the possibility that the folks you're working with who are 65 and up, 70 and up, if they start, complaining of a fairly quick onset of problems with concentration and problems with memory and increased focus on physical complaints and headaches and aches and pains and those kinds of things, and they may even have some reports of memory problems. Those are all indications that this person might be experiencing depression. Because again, that's not a typical sign of aging. Depression is not inevitable. So you want to be alert for it with those more somatic, maybe a memory component, with a quicker onset than you would expect with dementia. So just because it's a 67-year-old person who's complaining of energy and some concentration and memory problems. I just don't remember where I put stuff. It's been going on for a couple of months. That's not a cognitive, neurocognitive disorder presentation. And there's a geriatric depression scale, which is normed for a geriatric population that's really easy to use. It's just a bunch of yes/no questions. They can circle yes or no, and it will cue you that this is maybe more of a mood issue or not. Beck Depression Inventory is very popular, very widely used. The PHQ-9, very popular. We use it a whole bunch. It's also been kind of revised to be appropriate for adolescents. It's essentially the same scale. And they're available in PDFs online, so you can just print them and use them. Something too with geriatric, with an older adult patient, it would be helpful to do maybe a quick cognitive screen and a quick depression screen, and to help point you in one direction versus another. And what you'll find is with depression, that if the person is having difficulty remembering things or kind of thinking through things, just give them time and it will come to them. They're just slow. The cognition, the problem solving, the working memory, it's not impaired, it's just delayed. And that's another sign that this may be more of a cognitive delay due to a mood disorder versus a like a neurocognitive, what used to be called dementia. So we've talked about serotonin, and remember the main serotonin neurons start in the raphe nucleus, kind of in the midbrain, and then they shoot up and they connect to all kinds of places. They're involved in mood, they're involved in anxiety, they're involved in appetite, they're involved in sleep. Really important, the pictures in Stahl's book, because it's very, very condensed information. Dopamine as well, drive, impulsivity, learning, desire, pleasure. That's a dopamine thing. That is a dopamine issue. And energy and concentration, a norepinephrine issue. Norepinephrine neurons also innervate the amygdala. So that's when you think, oh gosh, fight or flight, all systems go. Attention in the frontal cortex for sustained attention and response inhibition. That's all frontal cortex. That's a norepinephrine issue. Each of these are amines. They're monoamines. And in the way back in the 50s, the theory was, well, maybe people just don't have enough of these things. Maybe it's a deficiency of these monoamines. That's why people are depressed. So let's just give them more, which I guess is a very American approach to things. Let's just give them more, and more will be better. Well, voila. Monoamine oxidase inhibitors, MAOIs, if you've heard that term. I'm sure you have. MAOIs were introduced in the 50s, and when people took them, their depression was relieved. And we talked about enzymes last go around. Monoamine oxidase inhibitors, MAOIs, all they try to do is prevent the degradation and inactivation of dopamine, norepinephrine, and serotonin, the amines. It's inhibiting MAO activity. So what you end up with is more available. Now, there are different kinds of MAO, different MAO enzymes in the body. Some are more selective to preventing the breakdown. MAO-A is an enzyme, likes to break down serotonin and norepinephrine. MAO-B is more selective. Its job, kind of what it seeks out to chew up and destroy, is more dopamine. And they tend to be, A and B, for the most part, selective of one versus the other. MAO-B is still used today in the treatment of Parkinson's disease. And with monoamine oxidase inhibitors, some are reversible, meaning it'll inactivate the enzyme and then let it go and do its thing, versus irreversible. It will lock onto that enzyme and it is not ever going to break down serotonin or norepinephrine again. So there is some nuance to these drugs. The problem arose in that a lot of MAO, that inhibitor, exists presynaptically, meaning if you don't have MAO breaking down serotonin, norepinephrine, dopamine, and it just builds up and builds up and builds up, well, if something occurs that causes the release of all of those neurotransmitters, then the person is just overwhelmed with norepinephrine, per se. So what do you think might happen if a person suddenly was flooded, if their central nervous system suddenly was flooded with norepinephrine? What might happen? What systems? Right, exactly. Blood pressure, heart rate, and then with serotonin you can experience, I bet they would feel a little anxious, absolutely. So yeah, you risk a hypertensive crisis with this tremendously high blood pressure, because norepinephrine is causing a lockdown of all your arterioles everywhere. And just think, if that was an irreversible MAO, it's going to be a long time until the norepinephrine can be broken down. So while these drugs were helpful back in the day, the risk was too great because of the potential for hypertensive crises, for serotonin syndrome, because there are foods, tyramine, look at that, amine, it's another amine, that if the person was exposed to foods, they call it the cheese effect. If the person was exposed to foods high in tyramine, that this would trigger one of those cascades where all of that stored up, all those stored up amines would get released, and you have a lot of tyramine gets broken down through an enzymatic pathway into serotonin, into dopamine, which is further broken down into norepinephrine, which actually then gets broken down to epinephrine. So if you just throw a bunch of amine ingredients into a person who is incapable of breaking that down and eliminating it, well, they will just be overwhelmed. So you still may see MAOIs used today, but because there are food restrictions and medication restrictions, you wouldn't want someone on an SSRI, SNRI, a stimulant, none of those things. That's why in so many medicines say don't take within 2 weeks of being on an MAOI. You will still see it used, though, for refractory depression. You will still see it used some. And with education, it doesn't have to be dangerous. There are just other things that came along that were less risky. Tricyclics was the next go-round, and it is a molecule that if we looked at it under, I guess, I don't know what kind of microscope, electron microscope maybe, it has 3 little rings. That's what makes it, hence tricyclic. Interestingly enough, trazodone is a tetracyclic antidepressant, so it's shaped not too differently from these tricyclics. One of the reasons why you don't want to treat people with a lot of trazodone and a lot of tricyclic antidepressant. They do similar things. So what these do, now we're talking about reuptake inhibition, right? These drugs are capable of inhibiting, blocking the transport proteins that are trying to vacuum serotonin and norepinephrine back into the cell so it can't go anywhere and do anything. Examples are Elavil and Pamelor, Doxepin, probably the main ones. But not only do these 3-ringed antidepressants block the reuptake of serotonin and norepinephrine, which can be beneficial, we just talked about, malfunctioning in serotonin and norepinephrine neurons can contribute to these symptoms. So let's increase it. They have anti-adrenergic, so anti-alpha-1, and anticholinergic, primarily antimuscarinic side effects. So when we talk about, oh goodness, anticholinergic side effects, the dry mouth, the blurry vision, urinary hesitancy, constipation. And when we talk about, oh, I feel so dizzy when I stand up, or actually passed out the other day when I was outside in the heat, you're going to more likely expect those effects with a tricyclic. Antihistaminic side effects contributes to sedation. Histamine is associated with alertness. You block it, you have sedation. These are used a good bit. Oh, here's a pop quiz question. If it inhibits the reuptake of norepinephrine and therefore makes norepinephrine a little more available in the central nervous system, can you think of an off-label use for tricyclics? I'm sure y'all are seeing this a lot in your clinics. Not related to mood necessarily. Norepinephrine is indicated in ADD. That is a good thought. Keep going down that trail. Drugs that promote norepinephrine reuptake can, if you think about Cymbalta, that's really what makes it different from SSRIs. That norepinephrine is involved in blocking and inhibiting pain signals from ascending up to the brain to where you would be aware of it. So you will see, because norepinephrine is boosted a bit in these drugs, that it can have reduced effects for pain, particularly neuropathic pain. So you may see folks who can't sleep and are having a lot of chronic pain, whether or not they have depression. You may see your preceptors writing tricyclics at night for them, and you're thinking, well, why are you doing an antidepressant for someone with pain? Well, that's because of the norepinephrine reuptake blockade. So patient education, be aware of anticholinergic side effects, be aware of orthostasis. The risk, though, with these drugs is potential for overdose, because more so than SSRIs, tricyclic antidepressants can affect cardiac conduction and increase the risk of dysrhythmias. With overdose, anticholinergics, if it's anticholinergic, then it is proadrenergic. So there is risk, and this is it, higher than treatment sort of doses, that you may have tachycardia, dysrhythmias. This is not a medication that you would write for someone who is, that you are concerned for self-injury, because there is the potential for overdose with these drugs. There's really not with SSRIs, but with tricyclics, you'd want to be more careful. And if they have a history of overdose, or you have concerns about the possibility, then this isn't something you would write. But for pain, for sleep, it can be really, really helpful. Ta-da! And now we're at SSRIs, which is probably the things you see done the most, I would suspect. Tons of different indications, depression, GAD, and it's different for each one. So I do encourage you to come up with some sort of memory device to memorize the unique indications for the different drugs. Lexapro's indications are not the same as Zoloft's, or Prozac, or Paxil. The typical side effects are going to be nausea, because serotonin, and I believe it's 5-HT3 receptors in the brain, is involved in the vomiting center and the the means by which your brain has to communicate with neurotransmitters. That's how everything has to get sent to everything else. And serotonin is the means for communicating nausea, and you need to throw up. So anything that boosts serotonin is going to temporarily, artificially create a sensation of nausea. This tends to go away after a few days, but that initial boost until those cells downregulate in the presence of extra serotonin, they're going to have nausea for a couple of days. You have more active serotonin and serotonin receptors in your stomach, in your GI tract, than you do in your brain. So there may be diarrhea is common, particularly with Zoloft. But the nausea, the GI effects, it's because serotonin is also how your how appetite, how GI functioning, how nausea, how all of those messages are sent is with serotonin. Serotonin tends to turn off some dopamine receptors, some dopamine neurons, I'm sorry. Serotonin doesn't do anything to dopamine receptors. It only activates serotonin receptors. But there are serotonin receptors on dopamine neurons, and serotonin tends to have a calming effect there. Serotonin also has a calming effect on norepinephrine neurons through a roundabout way. So it makes sense that if someone is low on serotonin, why they might be anxious, because serotonin's ability to lessen that noradrenergic, anxious, heart racing, jittery, sweaty. If serotonin's not there to turn it off, well, then you have this unregulated activation. At the same time, if you boost serotonin for mood or anxiety purposes, and that tends to turn off dopamine, knowing what you know about dopamine, what might happen if you boost serotonin and the relative levels of dopamine activity goes down? What might you see? Apathy. Yes, exactly. And you may have worked with folks who've said, I got on this medicine and I wasn't as depressed, but man, I didn't care about anything. I didn't care about anything. And that is why. So the depression improves, but you have this emotional flattening. People will say, I wasn't sad, but I couldn't laugh either. I was at a funeral and I couldn't cry. It's like I just didn't feel anything. And you don't want to do that. So thankfully we have, as you can see, lots of options for treatment. Start low, go up slowly. Tell people it's going to be best case scenario 2 weeks till you notice anything. Let's give it more like 4, and then we'll really reevaluate. Not an overnight thing. And I found a picture. Let's do this first. Uh-oh. Sorry about that. Had a technical difficulty. Trying to decide if I want to show this picture now or later. No, we'll do it later. Okay. SSRIs, best side effect profile. They don't interact with a whole lot of things. They're safe at overdose, which, that's not something we plan for. But you know that the therapeutic index is much, much, much higher. Serotonin syndrome is not going to happen unless the person has a genetic predisposition to it, or you give them a medicine like an MAOI with it. People aren't going to get serotonin syndrome just with an SSRI. We talked about how pregnancy is much more common in women, as is depression. Depression is more common in women, so what do you do for when women get pregnant and are depressed, or when depressed women get pregnant? Some SSRIs, you're not going to use Paxil. You're not going to give it to a woman who is pregnant because of a variety of well-documented teratogenic effects. But Zoloft and Prozac can be justified for depressed women who are pregnant, because what they find is that women who are depressed, not only does that mimic the hormonal environment to the fetus, there's a you're going to have a lack of certain neurologically supportive hormones and neurotransmitters that children born to mothers who were depressed are more likely to develop depression themselves, and they have brain structure differences that mimic a depressed adult. So there's physical risk. There's also situational risk to not treating depression in pregnant women, because the new moms who are depressed are much likely to bond with the infant, less likely to provide, the nurturing, feeding, basic things. Kids do best when moms and dads, caregivers, are not depressed. We'll talk about this much later in the term, but category D, category X, that's not used anymore. It's a more informative but less simple system for describing risk. As you're continuing to sort of memorize which ones inhibit and which ones don't, Paxil and Prozac, big 2D6 inhibitors, so you may want to be more cautious in dosing drugs that are 2D6 metabolized. Good thing about Celexa and Lexapro is they really don't interact with much. They don't inhibit anything. They don't induce things. They're very clean, in particular Lexapro. But like I said, we're going to come out with some a medication nugget PowerPoint soon. We don't have time to go into kind of all of that detail. I know y'all know about SNRIs when you see venlafaxine, when you see duloxetine. These not only inhibit the reuptake of serotonin, they inhibit the reuptake of norepinephrine, which is like an SSRI plus. There are similar indications. What's interesting about Effexor is that at lower doses it functions essentially like an SSRI. At a moderate dose, it has to get above 150 milligrams a day to have a sufficient concentration to block norepinephrine transporters. Really interesting. So the drug behaves differently at different doses, which really just speaks to its affinity for those receptors, that you need a much higher concentration for it to substantially act on those receptors. And it's theorized that at really high doses, it will actually have some dopaminergic reuptake. And that is probably because in your frontal cortex, you don't have much dopamine transporter. It's primarily norepinephrine transporter. And what happens is, if you pretty much occupy all of the norepinephrine transporters, then dopamine transporters step up and pick up the rest of the and kind of picks up the rest of the job. So what you have is dopamine transporters kind of clogged up with norepinephrine, which allows more dopamine to hang out and do its thing. And this relates to, they're both monoamines, and actually one is metabolized from the other. So the transporters for one can sort of do the job for the other two. Venlafaxine in particular, remember this has the risk for increasing people's blood pressure, more so than the other SNRIs. So particularly at high doses, you want to be closely monitoring people's blood pressure. Anything that is that involves serotonin reuptake inhibition has the potential to influence sodium levels. So probably some of the main things you're going to monitor for someone with any SSRI, SNRI is going to be sodium, and that has to do with these drugs tend to fit and act like antidiuretic hormone. And you know about antidiuretic hormone, well, that means, well, let me not diurese, let me hang on to as much water as I possibly can, so the person ends up relatively diluted of their sodium content. Symptom of inappropriate antidiuretic hormone is rare, but it happens enough with these medications, anything serotonin reuptake inhibition, that you want to watch sodium levels. Duloxetine Cymbalta can elevate liver enzymes. So for someone who already has a compromised liver, you would just not want to go with this. You would just not want to go there. I think, hang on one second. Don't go anywhere. I found a picture of a neuron. It's actually two neurons, one talking to the other one. If you remember from before when we looked at these pictures, you have the soma, the body, you have the dendrites to receive information, you have the really long axon with all the myelination, and then the terminal is near, obviously, the action end of another cell, to the nucleus, the soma of the other cell. Just to use SSRIs and reuptake inhibition as an example, because Stahl will tell you about different kinds of serotonin receptors. And again, a serotonin receptor just means a thing that receives serotonin. It can be on any cell. It just means it receives serotonin. So the way that we hypothesize SSRIs work is you have a serotonin neuron that for whatever reason is inactive. Let's say this is a serotonin neuron and it's trying to get serotonin downstream to this guy. This could be norepinephrine, it could be dopamine, GABA, could be another serotonin neuron, doesn't matter. The problem is that if this serotonin neuron is not producing, this is the theory, that if this serotonin neuron were producing more serotonin, then that would correct the relative imbalance at this cell here. I hope you can see my little pointer. That let's say this is a norepinephrine neuron and it's just overfiring because it's not having enough serotonin come down here and calm it down. Let's just say that's the case. Gross oversimplification. So how can we make more serotonin? How can we make this cell release more serotonin? It's not just dumping a bunch of serotonin here so that this cell is corrected. It's really about correcting the underperformance of the serotonin neuron. And the way that that's done is on this end. You would think, well, let's put more serotonin here so this cell behaves itself better. No, it's really about putting more serotonin here. Because just follow me with this. Stahl talks a lot about serotonin 1A receptors. And often when you see something 1, especially with serotonin, a serotonin 1 and then a letter receptor, it's probably an autoreceptor, meaning if serotonin lands on it, then it'll turn itself off. Like, oh, we got enough serotonin, I don't want to fry myself, let's shut it down. By increasing, so let's say you just have a bunch of serotonin 1A, a bunch of autoreceptors here. Let's say you have a bunch of autoreceptors. And anytime serotonin lands on that autoreceptor, it turns this cell off, shutting down any beneficial effect it was going to have down the road. So what if you flood these autoreceptors with serotonin? What happens when you overwhelm a cell, really anything in your body? What happens if you overwhelm receptors with a neurotransmitter that fits it? This is kind of coming back from, hopefully from patho and pharm, and it may not be. But when you expose a cell receptors to too much of something, yes, Jake, okay, who else said that? We got Ty for first place, Karen and Jake. Yes, that's exactly what you get. Because remember, we went on that big long tangent about G-coupled proteins, that what it may end up causing, neurotransmitter lands on it, it'll change how the cell actually operates. The cell may upregulate, may downregulate in response. So if you can flood serotonin and just overwhelm these autoreceptors, and the autoreceptors downregulate, what you essentially have is the cell is harder, this neuron is harder to turn off, because you've gotten rid of the receptors that say, hey, turn off. You've had enough, turn off. And probably what started the whole thing is that there wasn't enough serotonin getting to that cell in the first place. So when a cell is starving for neurotransmitters, it's going to upregulate and increase the number of receptors available to catch any serotonin that comes along. But what you end up with is, geez, I'm not getting enough signal to make this cell do anything, because there's a imbalance between the number of receptors and the available chemical. So SSRIs, SNRIs work by kind of fixing that, by flooding serotonin with these autoreceptors. It corrects this inappropriate upregulation that happened in the first place, theoretically. And now the cell is, okay, I'm balanced. I'll turn myself off when I need to. I can get turned on when I need to. And now the cell is, it's not getting locked down inappropriately. It's actually sending some signals down the road, which means this cell will start functioning more appropriately too. That is why it takes 2 to 4 weeks for SSRIs to have an effect, because it's not an overnight thing that suddenly the cell is going to get rid of all of these extra serotonin receptors that it built up. So it requires changing how chemicals are made and received in the brain. It takes a couple of weeks. And when they do scans of people's brains at some tiny level, they're able to see that, oh, it takes 2 weeks for that downregulation to occur. So it matches, the time frame matches the change in clinical presentation. Additional antidepressants. I know you'll see a lot of bupropion used. It's an NDRI. It's a norepinephrine, dopamine reuptake inhibitor. And kind of like we just talked about, when norepinephrine and dopamine can be transported by the same transporters. So if you inhibit one, you may actually increase the available chemical of the other. In the frontal cortex, it's going to be primarily norepinephrine and then dopaminergic. But bupropion's also indicated for ADHD, for smoking cessation. It's contraindicated for people with seizures because dopamine goes up and seizure threshold goes down. So that's why you wouldn't do that. You may also see Remeron used a good bit, trazodone, which we mentioned. Remeron is a unique mechanism. It's not an SSRI. It's not a, I guess, really anything RI. Alpha 2 is an autoreceptor that tends to slow things down. When norepinephrine lands on alpha 2, it says, okay, we're reaching capacity. Let's calm things down. So if you block alpha 2, that allows for the release of more norepinephrine. That's a good thing for someone who's, maybe depressed and blah and low energy and these kinds of things. Tracy had somebody with serotonin syndrome times 2. Now he's on Remeron. I would be interested. People are genetically predisposed to serotonin syndrome, so I wonder if he got genetics testing, if he would be able to find that. You can see on those tests if folks carry the gene to make them more likely to have Steven Johnson, serotonin syndrome, if stimulants are going to work, if SSRIs are going to work. Yeah, well, no more SSRIs for him. Gosh, I guess no more Buspar for him. So yeah, you can see the mechanism of action of Remeron. St. John's wort. Yeah, we'll talk later down the road about quote unquote natural things that can be really dangerous. That can be really dangerous. Yeah, St. John's wort really makes us want to ask people, what over-the-counters do you take as well? What are the medicines you take? What over-the-counters do you take? Serotonin 2 is one of those serotonin receptors that turns off dopamine. So if you want to boost enjoyment, boost interest, then prevent serotonin from blocking those things. And then serotonin 3 receptors, those are on GABA neurons. Now GABA is very calming, right? You don't want more GABA for someone who's low energy. You want to say, stop GABA. And this is another way that Remeron works. It prevents GABA from being inhibitory. You'll read in Stahl about disinhibits. It makes a drug might make things go, but really the way it works by making things go, it doesn't stop things. It prevents the inhibition of things. So in a roundabout way, makes things go. Disinhibit, a real common term. Tracy's asking about alpha 2. I don't believe that alpha 2 is out in the periphery. I believe that alpha 2 is more on the upstream end. So what I will do is verify that for you, Tracy. And you may be one step ahead of me, and you may have already looked that up. But my understanding is that alpha 2 is more centrally located, and it's not on the action end like alpha 1 is on little smooth muscle lining our little arteries and our little veins. But I'll double check that for you. I believe alpha 2 to be more central. So if you turn it off, then you think, whoa, everything downstream is going to go. Trazodone is a serotonin reuptake inhibitor that at very low doses tends to act just like a antihistamine. And at actually very high doses function as an antidepressant. We have more effective, more potent mechanisms now to address this. Yeah, 50 milligrams for sleep, 400 to 500 milligrams and up for antidepressant. You will never see, let me not say that. I'll be surprised if you see anyone on trazodone even above 250 milligrams, because it's just not commonly used for depression anymore. Other drugs that we'll put and talk about in that PowerPoint, newer ones, well, they're not even really that new anymore, but Vibrid and Trintellix, which used to be Brintellix, but it's Trintellix. It has a unique mechanism of action. Vibrate is essentially an SSRI with Buspar attached kind of with it. Trintellix has more noradrenergic activity, so it is considered more helpful for cognition, kind of cognitive symptoms of depression. We already talked about duration, how long it takes to get to see an effect, 2 to 4 weeks, best case scenario. Now, let's say the person doesn't feel, we'll do it easier this way. Let's say they come back, you see them back in a month, and they feel a little bit better, and they're still at their starting dose. What would you do? Vibrid. Cecilia was asking about the other one, Trintellix and Vibrid with 2 I's. Yeah, right. You would increase it. If they have a little bit of improvement on a little bit of medicine, then it would make sense to increase it. Sure. Let's say they come back in a month and they feel nothing, or their side effects haven't gone away, or they feel worse. What might you do? Yeah, absolutely. Change it. Most definitely. You should see some response in the positive direction if this drug matches their physiology. If you can get genetics testing to rule out things that are less likely to work, great. If mom, dad, brother, sister took Prozac and loved it, we'll start there. But don't just stick with the medicine if there's no benefit within the first 2 to 4 weeks. You should see something positive. And the longer you wait, the longer it takes to see a benefit, the less chance they're ever going to get a benefit. So that's the value of matching specific symptoms. Does this need a dopaminergic agent? Does this need serotonin? Is this a norepinephrine issue? Is it all of the above? You just want to make the best choice you can. These drugs have been studied and given FDA indications for certain things. Start with those. If the person has panic disorder or PTSD, don't start with Lexapro. You can't justify starting with Lexapro before you start with Zoloft or with Paxil, because those are the FDA indications for that. So be as precise as you can with your assessment and then match it to your treatments. But yeah, you should see something within 2 to 4 weeks. Otherwise, switch to something else. Titrate up as they tolerate. We can talk about cross titration in that recording lecture we'll put up. Remember, you got to rule out medical first. You got to rule out substance first. Are they anemic? Are they vitamin D deficient? Do they have sleep apnea? Are they on tons of blood pressure medications? Augmentation, we'll talk about that as well. It's very popular nowadays for people to be on some kind of antipsychotic to augment their antidepressant. You see that with Abilify. You see that with Rexulti. We can talk about Seroquel's role in bipolar depression when we do the bipolar. There will be a recorded PowerPoint uploaded into the file section for next week. We'll be at a conference, so we will not have class next Tuesday. But we will still present a lecture and talk about diagnostics and meds real similar. And again, you would titrate up as they tolerate. Some of these noradrenergic meds, like Effexor in particular, you don't want to boost it too quickly because you don't want to increase the availability of norepinephrine while the system can't adapt and downregulate in other areas where it needs to. So you don't want to just cause this sudden boost in blood pressure or panic or anxiety, which can happen if you increase it too quickly. And Stahl's prescriber guide will give you directions for that. Don't increase more than 75 milligrams a day every 4 days, those kinds of things. And also with stopping these drugs, gradual. There's no magic rule about how slowly to reduce medicines. I tend to do it, I'm sure, much more slowly than is really necessary, but I don't want to make people miserable if they're having to come off of a drug or switch them to something else. Some people will say, oh, just cut it and go down by half for 3 days and then stop it. That is just, oof, that's lightning fast, but you'll see it done a lot. If people have the luxury of waiting a week or two between reductions, drop it by a fourth, wait a week or two, drop it by a fourth, another fourth where you're at half. And there's nothing wrong with writing these instructions down on a piece of paper and handing them to your patient when they're walking out. Because this can be very uncomfortable when the body resets. So don't stop them all of a sudden. Don't run out of your medicines. Those kinds of things. So this is 8:10, and I'm going to turn into a pumpkin. So this is the last slide for today. Please be on the lookout for another kind of depression medicine nuance slide. And one announcement that we were going to make, and we'll post it in the course as well, on a much more serious topic, is the topic of exam integrity. And it has recently been brought to our attention that there are instances of folks who are figuring out ways to copy exam questions and save them to their computers, and then that information can be shared with other students who haven't tested yet. That information can be shared, people down the road. No one gets the same test because it's pulled from a test bank, but there's no way for us to watch everybody take a test in person, because we can't do that. We're all over the place. But it is very important to us to maintain the integrity of this testing material. So in the near future, please be alert that there will be changes made to how our exams are administered, because of our responsibility to maintain, to protect this material as best we can in a distance accessible program. Of course, it is in the honor code that copying and sharing exam items, exam questions, is a violation of the honor code, which can result in failing the course and having to wait to be considered re-eligible for coming back. So please, 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 don't do those things. Please don't do those things, because we can monitor everything that's done when folks are in the courses from an IT standpoint. And we really don't want to have to do that, but we will. So I say all that to say we appreciate those who are putting the work in and doing it the right way, and we'll put some extra measures in place soon to try to better protect the integrity of the questions, and it's really about making sure that the folks who graduate are going to go out there and be safe practitioners, because that's what we got to do. So if y'all have any questions or concerns about that, don't hesitate to email either me or Dr. Fogger. Again, we appreciate the hard work that all of y'all put into this, and we'll do our part to make sure that things are as they should be. Module objectives. Interesting. We can think about that, Ms. Parker. It's not something that we have historically ever done, but we can certainly consider that. Any other questions before we shut it down? All right, everybody. Thanks for being here. No class next week. Email us questions and comments and concerns, and we will get to you as quick as we can, okay?